this is our final one of the year. It is facilitated by the Professional Development Department. My name is Tracy Boyd, and I am the mentor for that particular Shared Governance Council here. Today, we're delighted to present It's as easy as ABCDEF. And our speakers today who are subject matters in each one of those letters. So I'm going to introduce the first speaker in just a moment. Those of you who are attending for contact hours, please make sure that you've signed in and have taken an evaluation form with each other in turn. First speaker is Lisa Ludlam, who coincidentally is the chair of the Professional Development Council and a ICU staff nurse on the day shift. Lisa?
Hello, everyone. Our ABCD, it's really a nationwide, evidence-based way that we wean our patients off ventilators and how we take care of ICU patients, really. So we're going to go through each one of the letters, and we're going to have each person speak about it. So it's just a standard bundle that we follow. And, every day we try to, get patients involved and families involved. And it's a whole collaborative, which is almost like a PTSD. Patients and even families, develop at the end. So this is our, whole interprofessional team. And we try to keep the patient and the family at the center of everything. So it's nurses, physicians, respiratory, the pharmacy, physical therapy, our dietitian, everybody is in there helping this patient to get better, faster, and not develop all those issues. So these are the letters that we go through. So, A is very important that we want to keep our patients comfortable and out of pain. So Sue will speak of that. B is both the spontaneous awakening trial. We wake everybody up every day and then do a breathing trial, right after that. C, our pharmacist will speak about the choices of medicines that we use to keep our patients comfortable. D is delirium. Many patients, just from the illness itself or the medications that we give them, develop delirium, which can extend their hospitalization and their illness. And then E is to get them up and moving, the early mobility. So our physical therapist and our mobility tech, Alex, will be down in a little bit. Most of you guys know Alex. He'll be here. I know. And then F is our families, and we have a few families and patients, ex-patients that have come to talk about their experiences, so that will be very interesting. So we'll get to that near the end. All right, and A is Sue. Sue Mogan is our pain specialist and palliative MP that does, multidisciplinary rounds with us every morning, and we tell her about our patients and what they need. So.
I'm so glad that I'm A. Because I have heart palpitations, as do I'm sure everybody else. So with pain, we want to assess it, we want to prevent it, and we want to manage it. So I have my cheat sheet. I hope I can just talk off the cuff here. But with assessment in our ICU, we use 2 different scales in our hospital. We use the numeric pain scale for people who are awake and alert and can speak. And that goes for people who are intubated also, because they can communicate with us. So we can ask them to utilize the numeric pain scale. And if they are unable to speak or they're sedated, we use the behavioral pain scale. As far as prevention goes, we must always try to, I don't want to use the word assume, but we should always consider analgesia. Because people are intubated, it's not pleasurable to have a tube down your throat. I don't know if anybody remembers, any of the patients or family remember that. But hopefully you don't remember it because we took care of your pain while you were doing it. So when anybody has organic reason for pain, we have to also try and prevent that pain from happening. And we do that, we manage it with bolus doses. As needed. So if we think that you're having pain through the behavioral scale or the numeric pain scale, we will give you short-acting drugs to take care of that. If we think you're going to have continuous pain, we may do short-acting drug boluses on a scheduled basis. And many times we also do continuous opioid infusions. Let me put my glasses on. I just don't want to forget anything. Also in assessment, we use the RAS score, which is assessment of sedation. And Kathy's going to talk more about that later. Primarily we use 4 different drugs. We use oxycodone and Dilaudid. Those are 2 oral medications that we can use. We can put those down in NG tube if we have to. Usually we do that for moderate pain. With more severe pain and people who can't take oral medications, we will do IV medications. And we primarily, well, we only use fentanyl, Dilaudid, and morphine. I'm not missing anything, right? So again, we use them as needed, or if we have to schedule them or give them continuous, we do. I know Kathy's going to speak about that also, so I don't want to get too involved in that. And we also definitely always use a multimodal care plan with pain medications. We don't want to only just use opioids. We can use IV Tylenol, or Ofemev it's called. We do that along with the opioids, and we can also use NSAIDs like ibuprofen and Toradol. And we try to utilize those to kind of keep back the need for opiates and for the reduction of pain. That's primarily what we're trying to do. So that's it. Good? Okay, so how do I click on here? I got it. Don't worry about it. Okay, good. Okay, so that's the behavioral pain scale.
Right. It also includes the compliance with the ventilator.
Right, yeah, right.
You know, narcotics help to just decrease that work of breathing if somebody's really struggling. So.
Right, so opioids kind of trick your brain into thinking that you're breathing better. It sort of just helps you breathe. So we do it in for the ventilated patients and unventilated patients. So Lisa, you're next.
I'm next, yeah,
Okay.
yeah. So, and Carol. All right, so we're going to talk about B, which is both. And it's both the spontaneous awakening and spontaneous breathing trial. Carol is one of our many respiratory therapists. We have a bunch of students in the back too. So we can talk to them a little bit about our breathing trials. So every morning we give our patients a sedation vacation. We wake them up, you know, we either turn the sedation off, or if we know that they need a little bit, we kind of cut back, you know, and we also try to cut back on the narcotics while we're doing that. And then right after they start waking up and you can see that they're assisting the ventilator, then respiratory comes in and they do their changes on the ventilator so that the patient does most of the work. And we have criteria on whether we even wake somebody. You know, if they're intubated just because they need a safe airway because they have swelling or they've had a seizure, then we don't, you know, do it. You know, there's a bunch of, you know, things that will exclude somebody from even an awakening trial. And then once we wake them up, there's exclusions to the breathing trial. But if they meet all of our criteria, then we start them. I'll let you talk about what we do.
On a CPAP mode,
Right.
where they're able to do all the work and they have a little support there. And once they're on CPAP for about a minute, then we do a test. It's called Rapid Shallow Breathing Index, and based on that, we
Either continue. Right.
continue the CPAP. And we also see the respiratory effort of the patient to see they're awake, they're listening to what I'm telling them, and they're breathing great. We do a blood gas, and if we get good results, then the patient gets extubated.
It's extubated. But we have a discussion with the physicians before
Yes,
we
we do. Yeah, we do.
do all that kind of stuff. But right, so they, there's a lot of steps before we get to the whole extubation.
Yes.
And a lot of times, we have to change things before we can get to the extubation. If they're very anxious, then we may have to change the sedation. We have different sedations that Kathy will talk about. Or if they're delirious and they can't follow instructions, it
We
makes
have
it
to
difficult.
put them back.
Okay. And so these are Sure.
Yeah, so this is just some of our data since we launched. We started this program in in December of 2015, where we started looking at how long the patients were actually on the ventilator. So we had, in the past, kept the patients on the ventilator for a little bit longer of a period of time until we started implementing this program where we can help wake the patients up earlier and get them off the breathing tube earlier as possible. So once we actually fully implemented, which was March of 2016, and we started doing this on a more day-to-day basis, then we were able to make the ventilator days come down from, let's say you were on the day for an average of 3 to 5 days. Now they're on the ventilator for an average of maybe 1 to 3 days. So it's not as long depending on what's going on with the patient, because some patients it's a little bit longer, and sometimes it depends on maybe we move over to a different mode like a tracheostomy where the breathing happens through a little hole that's placed in the throat, and we're able to then work on getting the patient off of that as well. But it's something that can be done more long term than the tube being through the mouth, and you're able to then communicate a little bit more with friends and family and with the staff on your needs and what you would like a little, and it's easier than having the tube in your mouth. So that is something that we've done, and over time we've trended this to look at how we've done. So this is just showing from September of 2017 up to September of 2018, the amount of days that the patient has had the tube, a breathing tube in their mouth for a period of time. So our numbers are relatively low. If you look at them, we had one spike in March of, for somebody that had been on the ventilator for a little bit longer period of time, and that, but overall, we do this breathing trial and awakening trial every single day to look at our patients and try to get them off as soon as we can.
All right, so C. This is Kathy Brandt, our wonderful pharmacist.
Actually,
And I'm going to read to you because I am so nervous. I didn't go to the gym today. This is my cardiac workout. So. Anyways, the C element of the ABCDEF bundle refers to choice of analgesia and sedation. The C element focuses on constructing a safe and effective medication regimen for the management of pain and agitation in critically ill adults. Recommendations are based on the PAD guidelines, pain, agitation, and delirium. Pain and analgesia. So routine pain assessments in the ICU patients are associated with improved clinical outcomes. The numeric pain rating scale is utilizing a scale for pain of 0 to 10, and the behavioral pain scale is used for patients who are unable to report pain scores. Here are the recommendations. So procedural related pain should be treated preemptively with analgesic agents or non-pharmacological interventions such as relaxation. IV opioids are considered the first-line drug class to treat non-neuropathic pain in critically ill patients. All IV opioids, fentanyl, hydromorphone, and morphine, when treated to similar pain endpoints, are equally effective. So for pain management in the ICU, here are the preferred interventions. So for acute pain, we use fentanyl IV push until the pain resolves. If acute pain persists or recurs, we may consider fentanyl infusion plus fentanyl IV push for severe pain. Acute pain in a chronic opioid user, we may have to consider what they have used before. So we account for their previous opioid use, and we may also have to consider using Dilaudid instead for a prolonged duration. When a patient is going to leave the ICU and they've been on an opioid infusion, we may start some scheduled oral opioid therapy plus intermittent IV push and some oral meds too for moderate and severe pain. So non-opioids that Sue talked about also, acetaminophen and COX-2 inhibitors, NSAIDs also may be used in addition to opioids. In patients with neuropathic pain, IV opioids plus oral or enteral administered gabapentin, carbamazepine, and pregabalin may provide additional pain relief. We'll move on to agitation and sedation. So sedatives are administered to ICU patients to treat agitation and its negative consequences. Efforts to reduce anxiety and agitation, including maintenance of patient comfort, provision of adequate analgesia, reorientation, and optimization of environment to maintain normal sleep patterns should be attempted before administering sedatives. If a sedative is required, maintaining light levels of sedation in ICU patients is associated with improved outcomes, shorter duration of ventilation, and shorter length of ICU stay. The Richmond Agitation Sedation Scale, RAS, is used to assess and measure the quality and depth of sedation in ICU patients. The properties of an ideal sedative are rapid onset and rapid offset, predictable dose-response relationship, ease of administration, lack of drug accumulation, few side effects, minimal drug interactions, promotion of natural sleep, and cost effectiveness. So here are the sedation recommendations for medication. Non-benzodiazepine sedatives, propofol and Precedex, are preferred over the sedation with benzodiazepines, Versed and lorazepam. Propofol has sedative, hypnotic, and anticonvulsant properties, but no analgesic effects. It has rapid onset of short duration, rapid onset of action in short duration, and long-term use can lead to accumulation and prolonged sedation. Side effects include hypertension, respiratory depression, hypertriglyceridemia, pancreatitis, and allergic reactions. Patients that are allergic to eggs cannot use propofol. Propofol infusion syndrome, or PRIS, is rare but needs to be considered when patients develop worsening metabolic acidosis, hypertriglyceridemia, hypotension requiring increased vasopressor support, and arrhythmias like bradycardia. Precedex has sedative, analgesic, and sympatholytic properties, which are very important because that's antihypertensive effects and beneficial effects on anxiety, panic disorders, and PTSD. It does not possess any anticonvulsant properties. It has a 5 to 10 minute onset of action and a half-life of 3 hours. Patients sedated with Precedex are more easily arousable and interactive. Side effects include hypertension and bradycardia. Benzodiazepines are indicated for patients with alcohol or benzodiazepine withdrawal. So clearance is reduced in patients with hepatic and renal dysfunction in the elderly and when administered with other medications which are hepatically cleared, thus resulting in delayed emergence from sedation. Analgesia first sedation is recommended in patients with a pain component of agitation, and IV opiates are first line. Fentanyl IV push and continuous infusion is preferred for rapid onset and short duration with less hypotension than other IV opioids. Sedative medications are titrated to a light level of sedation, and as Lisa and Carol spoke, daily spontaneous awakening trials and sedation interruption is used to wake patients and reassess mental and physical status. I'm going to talk just a little bit about delirium because Angela's going to give you more. Delirium is associated with increased mortality in the ICU patient. So here are the recommendations from the PAD guidelines. Benzodiazepine use may be a risk factor for the development of delirium in the ICU. Precedex infusions administered for sedation may be associated with a lower prevalence of delirium as compared to benzodiazepine infusions. In the current PAD guidelines, there are no recommendations for pharmacological delirium prevention protocols. So we're not using Haldol, we're not using Precedex, we're not using Seroquel to prevent delirium. There's no published evidence that treatment with Haldol reduces the duration of delirium. There is some evidence for atypical antipsychotics like Seroquel may reduce the duration. And atypical antipsychotics are not recommended for patients with prolonged QTC or receiving concomitant medications known to prolong QTC or who have a history of arrhythmia. Angela's going to show you a slide of drugs that also may precipitate or contribute to delirium. So in conclusion, we want to obtain a level of pain control and sedation that provides safety and comfort to our critically ill patient. Choosing the appropriate drug, the dose, and the titration schedule will impact the patient's course of treatment and time to recover. As we sometimes say in the ICU, this is Lisa all the time, less is more.
All right. So we do our level of sedation by our RAS scale, by how awake the patient is, and and usually the physician will order, like if they're on a continuous drip of sedation, a certain level where they want the patient to be. So we titrate our drips to, to that spot, hopefully. It doesn't always work, but this is our...
-1 is usually our target.
Right,
We want you to be drowsy, but not aware of things, but able to maybe
To
respond
wake
to what
up
we're
and,
doing.
answer questions and all that kind of stuff, so that's our RAS. All right, and next is D, and delirium. So Angela Watts, one of our ICU nurses, who also has her master's, is going to talk about our delirium and our CAM assessment.
All right, so I'm glad that I got D for delirium, because honestly, the bundle that we're talking about today, that's really what it's about, is delirium and preventing delirium, because delirium can lead to PICS, which is post-intensive care syndrome. And it's something that we really want to try to avoid. When I started nursing like 100 years ago, we kept people, maybe some of you remember this, we kept people sedated, in bed, in a dark room, flat, restrained, and heavily medicated, because we didn't want them to hurt themselves, or us. But things have changed, and the ABCDEF bundle is helping to change that. The aim of the bundle, that we're talking about today, again, is to try to decrease the incidence of PICS. And the D component of the bundle addresses delirium. So what is delirium? Delirium is a disturbance in consciousness with an inattention accompanied by a change in cognition or perceptual disturbance that develops over a short period of time, from hours to days, and it can fluctuate. It's amazing, but up to 80% of mechanically ventilated patients develop delirium, and it has, with it, it comes with an increased length of stay, decreased survival, and an increase in cognitive dysfunction. So basically, delirium is to the brain what an MI is to the heart. So you can see that that's very, very serious situation that we're trying hard to avoid. Some causes of delirium: dementia, so a previous history of dementia, electrolyte disturbances, any diseases that affect the lungs, liver, heart, kidney, or brain, an infectious process, medications, as Kathy said, and some of them are opioids, benzodiazepines. Those are things that we use frequently, but if somebody is delirious, we would try to avoid those things, as well as other medications like centrally acting blood pressure medicines and antihistamines. Injury, pain, stress, everyone has that when they're in a patient in the ICU. An unfamiliar environment, you're in a room, sometimes a dark room, in a place that's not home, so the chances of you developing delirium are higher. And a metabolic disturbance, such as anemia, hypoxia, malnutrition, hydration, alcohol withdrawal, low blood sugar, those types of things. So the CAM ICU is the scale we use to determine whether somebody is developing delirium. It's a very quick, easy to use scale, and we start using this on everyone right away. It looks at whether there's acute change or a fluctuating course of a mental status. If the patient has inattention, if they're not able to squeeze our hands when we say the letter A and really focus on what we're asking them to do. We also look at their level of consciousness and whether they have disorganized thinking. And once the scale is done, it takes literally minutes to do. It's very quick. We determine whether the patient is CAM positive or CAM negative. If they're positive, we discuss that with the doctor right away on morning rounds. We very much work as an interdisciplinary team. As soon as we identify that somebody is CAM positive, right away red flags go up, and we get a team effort in place to see if they're on opioids. We're going to discontinue those. Make sure the lights are on in the room, make sure that we're doing the awakening trials and all the things that are needed to help prevent delirium. So in our unit, these are the stats for delirium in our unit. We've had, for example, in September of 2018, 5 CAM positive results on that CAM assessment that we do, which is a 5%. So we are fortunate to have a great team approach and support from the Northwell Collaborative. This isn't something that we just do here. This is done all across the whole Northwell network. And it's also done everywhere, and most ICUs have adapted it. But we're fortunate because this helps to guide us to decrease the chances of delirium and in turn decrease the chances of developing post-intensive care syndrome.
Beautiful.
Marty's one of our physical therapists, and Alex is our mobility tech in the
Hello everybody, I'm
ICU.
Marty from Physical Therapy.
I'm Alex, Mobility Tech, the ICU.
So we're going to talk about early mobility. So everybody knows the importance of getting patients up and moving. I know, Angela, you talked about in the old days, you used to keep patients sedated in the room, lights are out, and you know, it's almost like a prison for these patients. They hear lights, they don't see anybody, but the goal is to get patients up and moving to normal activity. So this is where mobility comes in. So mobility is, you know, by definition, just moving. It could be just sitting at the edge of the bed, could be walking, could be rolling, could be anything that requires the patient to move. And it's important because it helps with bodily functions, from normalizing their blood pressure, taking pressure off their skin. Psychologically, it's very important. If their patient's in bed, lying down all the time, you know, versus getting up and walking around, it's a big change. So the goal is to mobilize these patients as quickly as possible. All right, so one of the big things is, besides these other things that we see for patients who are mobile, the dreaded ICU weakness. You know, patients who are critically ill, you know, if they're on a ventilator or if they're critically ill on a lot of meds, they are susceptible to getting critically ill weakness. If it's polyneuropathies or if it's myopathies, it is general weakness. And once you get to that stage, it's difficult to wean, more difficult. Again, I think the additional days, ventilated days, goes up by a lot, increased mortality. But even after patients leave the ICU, they have continued problems with weakness and mobility. I don't know if some of the patients are going to talk about that. But once they get into that phase of weakness, it's really hard to kind of get to the next phase. So it's so important to get them moving early as possible. Like I said before, mobility is something that everybody does. It's not just PTs, it's the nurses, it's the mobility techs, it's the PCAs. The goal is to get them moving. So if the patient's in bed, maybe they were using a bedpan, we need to get them up and using a commode. We need to get them to dangle. Even just dangling, you know, some patients are really critically ill. Just even sitting at the edge of the bed where they can actually just be in a birth position, they can mobilize secretions. But even just, again, psychologically, they know they're getting better. If they're lying in bed for a few days and now they're sitting up at the edge of the bed, they're actually, you know, doing much better. And this is kind of a general protocol, you know, that we use, physical therapists use in the ICU. When do we start the mobilizations of the patients? You know, these patients are critically ill. So when are we going to go in and start mobilizing these patients? So again, there's medical criteria that we're going to be following. You know, we work as a team with the intensivists and the nurses and the respiratory therapists. We want to make sure that if we're going to get them up, that they're actually stable. So we're going to make sure that cardiac-wise, oxygenation, their medications like vasopressors are okay. So the goal is to get them up and they're medically stable. So now we're going to get them up again, level 1 to level 4. It's the whole gamut. So level 1 is someone that maybe we can't get up yet, but maybe the nurses or the PCAs or mobility techs can start range of motion. You know, they can start moving the patients in the bed. Versus level 4 is that we're getting them up, we're walking with the walker. Alex or Indy is walking with them, walking, tell them how blue their eyes are, and talk about
But when you talk about mobility, we think about two things very important. One, mobility. We have to mobility the patient as soon as possible, as Mary say, and we have to be safety. That's very important. So we work in the ICU, and the patient usually when they stay with us, they stay more depressing, they stay in bed for a long time. So that's big issues for us when you have to take this patient and start to mobility, you know, to start to work with them. But we are very lucky because we have a wonderful team together. We have a physician, we have a respiratory, we have a nurse who has at least 32 years of experience there. And I think it's the best medicine in the world. Like it's like changing the mood, the patient. So when you come to the patient, so they are frustrated because they in the ICU. They have a lot of medication. What's going on? We have patients and he can't remember this. So and especially for me, it's like it's wonderful when they come to see my patient. And before I got a report for the nurse, for the physician, for everybody, and they look me and they say, "Can I move today?" And yes, let's move today. So in my situation, like I want the patient to be safety. So I check the wires and I speak all the time with the physical therapist. I say, "Hey Marty, I have this patient in here. Can I move you with them? Can I?" So, but the goal is like move and be safety. That's our goal. Safe. That's my high five.
So this is pictures of some of the success stories. So on the left, this was maybe one of our first patients that we saw. Was the first patient when we started the official protocol. And again, you see he is ventilated. He is alert and awake. And it looks like, if you look, I call those ICU acquired legs. If you look at him, he is atrophied. You know, he's been sick for a long time, so he has been able to walk. I think he was using a walk before actually he came in. So, but you know, it doesn't stop us from actually mobilizing him. You know, even though that he's critically ill, he's alert. He's able to follow commands. And he's able to work with us. So now, you know, stage 2. This is the difficult part, and this is where the whole team comes into effect, that there is a lot of lines. There is the ventilator that we have to switch from a regular ventilator to a mobile ventilator that we have. So, and it's a small room, so we really have to kind of, you know, clear the space, get all the personnel involved, get clearance from everybody. But we can actually get him up and walk. So we might have taken a step or two with this patient. But, you know, again, going back to psychologically, that he can get up, he can stand up and walk is such a big difference to these patients. Getting back to normal activities is what we're trying to do. Get them to, you know, brush their teeth, go to the bathroom is so important.
To me over there, huh? Not me, the patient.
And over there, the last one, I forget exactly, I think she is on a trachea. And again, you know, when something like this happens in the ICU, you'll see a whole bunch of nurses, and I think Ann was cheering these patients on.
It's a huge celebration.
It's a big celebration. So we got this person, I think we walked up and down the hallway the first time up. So it was a big success. So, and that's when then Alex takes over and Indy takes over. They continue the exercises. When they get better, they walk them around the hallway. It's great. And they do so much better when they're mobilized.
Yeah.
All right?
Good. Yes, thank you.
Anne's going to talk about our
Favorite parts of the
families,
bundle.
our ICU manager.
All about family. So Angela alluded to post-intensive care syndrome, and there's also something called PICS-F, post-intensive care for families. So our family members are also susceptible to experiencing post-intensive care syndrome, which is like post-traumatic stress, which everyone's familiar with. And it can have lasting effects for patients and for families. There can be cognitive impairment, thought process, memory, physical impairment, psychiatric. So all these things can impact the patient's recovery, and even after they get out of the hospital, returning to work, integrating into everyday life. So what we've seen across the country is clinics actually open up. Vanderbilt has one, University of Indiana, where patients can go for continued therapy, for support. Other families can talk to each other about what they've experienced and how do we help patients to continue to move forward. So this is a brochure that Michelle and I wrote. We give to all patients that enter the ICU. I'll pass it around. You actually got it. You came in, but there's more on the side. And it actually just educates everyone, how does the team work together? Because we're an interprofessional team. What can they expect during their stay? Communication is so key. So again, with the family members, how do we engage them in the patient's care? To be involved, to reduce their anxiety, to participate in putting lotion on the patient's hands, a gentle massage, turning the patient. We talked about delirium again, so patients lose gaps of time, you know, what has gone on. They help to fill in those gaps of time by talking to the patients, bringing in pictures, you know, talking about events that may have happened, again, to help the patient fill in what they may have missed. And we also talk about all the elements of the bundle. So this just shows, again, we like to keep metrics to make sure that we're educating and teaching families, so all the elements of the bundle, that we're providing. And the big thing that we're very happy about, we're starting a research study about family needs. So are we actually meeting the needs of family? And there's a couple of interventions that we want to group together that have been in the literature. So providing a diary so that we can write entries about what's happened to the patient. What milestones have they reached? What events may they have missed? And the families can write in that diary, and it's something that the patient takes with them, again, to reduce that incidence of PICS after they're here. Also targeted teach-back, and including the patient in rounds and the family, so they can hear what's going on. Okay. So,
Yeah, maybe we'll just want to tell them what we've had in there that is not there now.
oh, so the other thing that we were very proud of, we're one of just 3 or 4 hospitals of the 21 in the system that have successfully implemented all the elements of the bundle. And I just want to give credit to Michelle, our educator, because she really did a tremendous job educating the team and also setting up our documentation to make it easy to track that we're implementing all the elements of the bundle and being able to collect the data. And we did receive an award by Northwell because we've been able to consistently implement all the elements successfully. And we wouldn't be able to do it without a great team. And it really takes all our subject matter experts to make it happen, and support from our leadership and administration to do that. So the other thing is we have 2 families that have been gracious to come today to share their experience, what they remember, and for the family members, what it was like for them, what they observed, and what life has been like since they left the ICU. So this is Mrs. Blair and her sister Evelyn. This is Mr. Gage and his wife Mindy. And if each of you could just share a little bit of maybe about what you remember, what your experience was, and then you're all welcome to ask questions. Okay, so we always learn when we can hear from our patients.
Who wants to go first? I'm just going to tell you about the first 5 days. Kathy entered. Oh. Kathy entered here on March 22nd.
She had sit here so it's easier so I don't have to keep turning around.
She had lung surgery they hadn't found.
That was my strength.
She was. So, she was fine after surgery. Thank God the cancer is gone. Lymph nodes are clean. However, the next day, she was breathing in oxygen and not letting out. So she was on the breathing. Friday, Saturday, Sunday. Just do Susan. And many of you kept telling me, we have to keep going. And I said, no, you can't do this. She has to come off the breathing tube. And he says, she will pass. I said, yes. Fortunately, as our health proxy, she started to become a little coherent.
We ask her.
Dr. Stubacker, Dorothy, and Ann. They sat with me in a room. They sat with her, explained everything. I still did not want to give in to her having a trach. The next day, Dr. Stubacker said, please let Dr. Rohan talk to you. So the next day, my sister and I were here. And Dr. Rohan came in and explained to her, Kathy, because she knew at that point she was coherent. The care every day was, I never came in and saw less than 2, 3, 4 nurses in the room with her. The concierge was terrific. The nurses were terrific. I never went home and said she's not being taken care of. So Dr. Rohan came in and he explained to me that the trach would be temporary. And I said, well, I can't make that decision. I mean, it's hard being a health proxy, let me tell you. Dr. Rohan explained to her that, Kathy, do you know that if we take the breathing tube out, that you will pass? And she shook her head, yes. He says, we want to do a tracheotomy because it's just temporary. You will be able to breathe. And we just feel it so soon after pre-op, they just kept pushing. They just wanted to keep helping her to stay alive. She said yes. Whoa.
And she went like this, yes!
And within 30 minutes, I don't know how many nurses and an attendant came in because they had to take the tube out, and I couldn't believe all the people that surrounded her. They took her in, they did the trach, and she came out, she was smiling, and I'm thinking, oh my God. And I was like, oh, to think that on March 23rd, we thought she was gonna be gone. But everybody, the concierge, I would call every day. They were always pleasant. There was a tall black girl, she was an aide, and she would come into our room where we'd be sitting outside, you know, the patient, and she would say, she's gonna make it because you're all here, because a lot of my family did come. Unfortunately, at the beginning, I was the only one here because my sisters live in Florida and one lives in Maryland, but they eventually came up and saved the day. But she did get agitated, but it didn't matter. The nurses came in, they calmed her down. A few times I thought she was going to pull out the breathing tube, but she doesn't remember, and I panicked. Nurses didn't panic. They came in, they took care of her. Till this day, the caregivers, they still call me to see how I am. Till this day. It's amazing. I can't, it just goes beyond the call of duty itself and so on. And Beth and Matt, they were the respiratory, they came in on Friday after, and they tried to work on her for almost 3 hours, nothing. So every day, of course, they did the trial breathe. I didn't know everything. I'm here and hearing what you guys did in the morning. I knew it was early, but I never realized. And Alex was always the, okay, Gabby, come on, keep it doing, come on. Then she went up to the 7th floor. She was released April 6th. That day, we found out that where she was supposed to be going to rehab, they had put in the wrong insurance. Deborah, who has retired from the within hours, she had her situated in another rehab, and we went off. And I just want you to know that this is an exceptional, and this was emotional, it was medical, it was emotional, it was personal, it was comforting. March, the speech, we were talking, she was telling me how she makes her matzo balls. I mean, it just was a wonderful, it wasn't a great experience because seeing her suffer that way for a while was not the best. But anyway, she left here April 6th, and there she is.
What do you remember? Is there anything you can share that,
Well, I tell you, the only thing I remember when Eddie came to me and said that it was gonna be temporary, and I said, fine. I remember at one point I woke up, I have a large family, a lot of nieces and nephews, and it was like, oh my God, what are they doing here? They were all around my bed. And I says, I didn't know what was going on because I really wasn't that coherent. So then finally, I heard I was in room 9, then I went to 4, and let me tell you something, that 4 was the best room in the house. I had so much fun with the nurses, with the doctors. I just enjoyed it. That I had a sleep apnea after being released, and because doctor said I had to have it. So I said, okay, I'll go. So I went. And I get up there, and now I'm mad because I hate all those wires and everything. So I said to the gentleman, I said, you know, I had the greatest time in ICU. And he goes, ma'am, you were the first one that said that you had a good time. But I also want to tell you, each and every one of you were so wonderful to me. That Dr. Schumacher, Dr. Rohan, Dr. Weinberg, I mean, just unbelievable. This guy, right here, he was my joy. I'd see him, that was it.
I remember when they told you you're supposed to go into the floor, and you look at me, but you go with me. I want to stay.
I'm telling you, I had nothing but great, great feelings for ICU in Northern Westchester. The nurses, or the staff, whatever. I mean, one day, Easter Sunday it was, my niece comes to see me with an Easter bunny and Easter ears. And I put the Easter ears on, and we went around the floor so that everyone could see, here's this lady. Oh, then I had another day. But Northwell, is it?
Oh, yeah.
They came to visit. Well, now I'm
that was
recovered. I'm recovered, and now they decide to use me as an example. And I went. It was just so amazing. And I have to tell you, the care that I got, the bathings, the changing my bed, bringing me the potty, bringing me the chair to sit on so I didn't have to do that stupid thing under my bottom. And it was just amazing, and I tell everyone, no matter who I talk to, and I go like this, I am so proud of this. It's beautiful. I mean, I don't even know it's there. And thank God. And I have to especially thank my sister. She was there for me the whole time, and she's still there for me. And I have 4 other sisters that are there for me. I'm so glad this is where I came to have my operation. Believe me. God bless you over and over again. Thank you. I have good days, bad days. But when I have a good day, watch out. Oh! I'll tell you another story.
I love that.
I wanted to eat so badly that ice. After a while, it really got enough is enough. I said to Dr. Sumac, I said, can I have some food? Or even a vanilla malted because it goes down easy? Because I still had the trick in it. And he says, okay, when you're better, you're going to have your vanilla milkshake.
You got it, nice.
So one of our other patients is Mr. Gage. What?
Thank you.
So, I don't really remember much. Literally even before I was sedated. You know, I walked in, I think my body just shut down. So I really can't speak to a lot of things, but I heard a lot of stories. And it was really remarkable what you guys did. You know, my family is, they're a challenging group in the sense that they all have very strong wills. My son-in-laws, my daughters, certainly my wife. And I didn't really realize how sick I was, but I guess I was. And remarkably, when I woke up about 7 days later, I'd say within 2 days I was out of here, and 2 days later I was back at work. But I mean, I was emaciated. I had lost 20 pounds, but I still got out of bed. I made them. I wasn't here at that point. I was in Manhattan, but I made them walk me around. First with a walker with the tubes. We got rid of those within about 3 hours. Then I went to a cane, and then I insisted that they get a PT person in, and I walked up some stairs, and I was out of there. Had an aid, which was a waste because I was ready to go. But while I was here, my birthday was shortly thereafter, about 6 weeks later, and we all got together in a restaurant and had a bottle of wine. And I raised a glass and I said, to the best man. I said to the best family ever, everyone started crying, except for me. And I'm looking at them like, what's going on? And the stories that came out about the challenges that you guys had, the not knowing what to do, but the reality is me seeing when I was awake for the 2 days in Manhattan and seeing what I heard here, it's night and day. You know, you guys were tolerant. I mean, my oldest daughter will drill anyone to the ground. She is persistent. She questions everything. And you know, my wife is very caring and relentless, and you guys were incredibly tolerant. I think, you know, life is about a bunch of lucky things. You know, you're lucky when you go to the right place. You're lucky when, you know, you're choking and somehow someone gets here quickly and helps you out. I was just lucky. And the reality is, you know, I didn't realize, you know, put it in perspective, I play golf. And I went to the course about 3 weeks after I got out because it was starting to get nice weather. And I played horrible. And I sent an email to my foursome just saying, like, I'm really embarrassed. Like, you know, I shot like a 95 or something. And the guys wrote me, this one guy wrote back and goes, dude, like, you just got out of the hospital. Well, a bunch of us just went away on a golf trip. And one of the guys, he was there, and I shot 75. And I didn't even put, you know, like I missed a ton of putts. And it was like, it kind of like, it put it in perspective to me. Sometimes, I don't know what you felt, you don't realize how sick you are. And it takes like, you know, something within you to sort of put it in perspective. So, you know, it is an incredible team. It's an amazing situation that you have here. But I think in the end, you know, you just gotta be lucky. When I went to my specialist, and he kept shaking his head, looking at my lungs all the time, and he goes, and I said, what's the matter? He goes, I just can't believe, like, it's like two weeks later, it's not even a scar. And I said, oh man, I said, it must be because I'm really into physical fitness, like this and this. And he looked at me and goes, I hate to tell you, it's just genes. And he said, you're just lucky that it all went this way. So regardless of the luck, part of it was here. And I said this to Ann, who happens to be my neighbor.
They helped me, I locked myself out of my house.
And my first response is, are we even now? It was special. And again, you know, I thank you, not just for me, but really for my family, because it was really tough on them for like a week. And for me, it was just like, you know, you wake up and, you know, I was young enough to get going, and everything is fine now. So, my wife will be very nervous and challenged, so she's going to be quick. But again, thank you guys to the bottom of my heart.